Good afternoon and welcome. My name is Tim Poe. I'm Director of Telehealth with the UNC Cancer Network. Thank you so much for being with us here today. This is June 28th, and we're here for a medical and surgical oncology lecture. Just a few things to go over before we get started. If you get stuck for any reason and need our help, you can email us at unccn@unc.edu. Better yet, call or text us at 919-445-1000. We'll be using Poll Everywhere and I'll explain that in just a moment. We're on the web at unccn.org. You can find us on Facebook, on Twitter, on YouTube. So we hope you'll find what you need and reach out to us as needed. All right, we're going to start out in just a moment with a poll. And the poll question is, nearly all patients with myeloma will eventually experience relapse. A, true, B, false. And the way you respond to this poll, there are a couple of things you can do. One is you can go to pollev.com/UNCCN. So pollev.com/UNCCN, and you can respond there. It may be easier for you to go ahead and use a phone. So any phone with a texting capability, you can just text to the number 22333. The letters UNCCN. So you go 22333 as the number you're going to text to. You'll put in the letters UNCCN. Then you'll get a response back, something like join, letting you know you've joined the poll. Then your next text, if you think the answer to our poll is A or true, go ahead and put in A. If you think the answer is false, go ahead and put in B for false. We'll see that in real time in just a moment. I do have a disclosure statement. This activity is planned and implemented under the sole supervision of Thomas Shea, MD, the course director, in association with the Office of Continuing Professional Development. Thomas Shea, MD, consults for Spectra Pharma and receives research support from Millennium, Otsuka, GSK, BMS, Novartis, Seattle Genetics. CPD staff have no financial relationship with commercial interests. Let's see, the speaker, Brandy Reeves, MD, does not have any financial relationships with commercial interests. All right. Dr. Brandy Reeves is an associate professor of internal medicine for the Division of Hematology Oncology at the University of North Carolina at Chapel Hill. Dr. Reeves' primary research focus is evaluating assays for and mechanisms of thrombosis in Philadelphia chromosome-negative myeloproliferative neoplasms. In 2014, Dr. Reeves was recognized as an outstanding fellow by the North Carolina Oncology Association. So, Dr. Reeves, welcome. Glad to have you here today.
Thanks. Nice to be here.
Before we get started, tell us what led you to a career in oncology, if you would.
Yeah, so I've actually always been interested in oncology from a very young age. I got a chemistry set when I was 8. Pricked my own finger, started looking at things, putting various cobalts and things on the blood, and I've been fascinated ever since.
Right.
So spent time in Philadelphia with hemophilic dogs,
wow.
and has kept my interest ever since.
Okay.
So, I knew early on.
Okay, and a plug for those chemistry sets. We can put a link at the end of the presentation. That's great. That's great. All right. Well, with that in mind, we'll go ahead and turn this over to you. Oh, but before we do that, let's take a look. Oh, I think we're trending here. All right. We've got 80% saying that nearly all patients with myeloma will eventually experience relapse, and we've got just 20% saying false. And so if you'll weigh in as the expert and let us know what was the correct answer.
Absolutely. The correct answer here is A. Nearly all myeloma patients will eventually experience relapse. I suspect that maybe those transplant folks in the audience might have chosen false in the hopes that transplant will cure myeloma. That is not generally the case in multiple myeloma, and we'll talk about that in just a bit.
All right. Well, thank you. And thank you to everyone who submitted an answer to that poll. At the end of the presentation, we will have the opportunity for you to submit all kinds of questions to Dr. Reeves. So if you want to be jotting those down, and when we bring up Poll Everywhere again, it will be in a Q&A format so that we can accept those questions and she can address as many of those as we have time for. So please be keeping in mind your questions as the presentation is taking place. I will move us to the next slide and move this over to you.
Excellent. So We're going to talk about several things today, including when should treatment begin for relapsed and refractory multiple myeloma, which and how many drugs to use, how long should treatment continue, and what is the role of an autologous stem cell transplant in the relapsed and refractory setting. So first off, let's start off with some definitions. What is relapsed myeloma? Well, that is disease that has been previously treated with therapy and has recurred, versus refractory, which is disease that's resistant to certain drugs, either with no response or loss of response to treatment, or progression within 60 days of stopping the last therapy. And as the question pointed out, nearly all cases of myeloma will relapse eventually despite their response to therapy. So what is the prognosis of relapsed and refractory myeloma? At relapse, the disease becomes increasingly refractory, and the patients often have shorter duration of remission. And historically, an overall survival of 9 months was expected if the patient was refractory to bortezomib and an immunomodulatory agent like lenalidomide or thalidomide. And bortezomib-based regimens are the standard of care in first-line treatment for multiple myeloma. And in 2017, nearly every patient is going to be treated with a triplet of lenalidomide, bortezomib, and dexamethasone. There have been many new drugs introduced since 2006, with at least 3 of those coming in 2015. And as you might expect, overall survival does seem to be improving. And reflected here, since 2006, patients who have received greater than 3 lines of treatment who are refractory to a proteasome inhibitor, such as bortezomib, and an immunomodulatory agent, such as lenalidomide, and who had been exposed to an alkylating agent, as in melphalan for a stem cell transplant, now have an overall survival of 13 months. So we haven't quite doubled overall survival, but certainly we're extending it at this time. So when should we start treatment? So there are 2 sorts of progression when we think about myeloma, and one is just biochemical progression. So generally we are detecting, so every month the patient comes in, we do a physical exam, a history, and we grab labs that include a serum protein electrophoresis, immunofixation, and serum-free light chains. And we're monitoring in there each time what is the level of their M protein or myeloma protein, usually in the serum, occasionally in the urine, and what are their free light chain levels in the serum. And the free light chain levels are quite sensitive to pick up early relapse. So biochemical progression is if we have greater than 25% increase in the nadir, or lowest point, of the serum M protein, and that increase has to be greater than 0.5 grams per deciliter. The urine M protein with an absolute increase of greater than 200 milligrams per deciliter. Bone marrow plasma cells, if you do a bone marrow biopsy, of greater than 10% increase in a patient without a measurable M protein in their serum, and a difference in the serum-free light chain levels of greater than 10 milligrams per deciliter. In those cases where it's just biochemical progression and the patient has otherwise no symptoms, you might observe. In the case of clinical progression, which is where you actually have symptoms from the progressing disease, if there are new or increasing plasmacytomas, unexplained serum calcium greater than 11.5, or progressive anemia, then you're going to want to treat because the disease is active and not just biochemically progressed. You might also consider treating biochemical progression if the doubling time of the M protein is less than 2 months, if there's high-risk disease, or if the patient's initial presentation was that of significant renal failure or lytic bone disease, when actually becoming clinically symptomatic would be problematic to the patient. So what are the disease factors that might influence treatment? And one of those that might herald that the myeloma has become more aggressive is that of clonal evolution. So if there is something called free light chain escape, where the patient used to make a protein that was, say, IgG kappa, and now what you're picking up on their laboratory evaluation is a lambda free light chain, well, that is a different myeloma clone. And if you see here, at diagnosis, there are usually several different myeloma clones present. So it's not just one tumor cell. This is a heterogeneous tumor. You treat, say here, with lenalidomide and dexamethasone, And your tumor looks a little bit different over time with that treatment, with this orange clone becoming more prominent. You give continued lenalidomide and dexamethasone, and now this green clone becomes more prominent because you're selecting against the ones to which it's sensitive. Then you have disease progression, and you start a different agent, in this case carfilzomib. You see the clone changes. Once again, this dominant clone goes down, another dominant clone arises. You have disease progression, you change therapy, and the course continues. And so as we treat, we think that we are selecting for various clones, and previous clones may re-arise. Hence our recommendation at times to reincorporate drugs to which the patient was previously sensitive. Other evidence of clonal evolution would include the development of extramedullary plasmacytomas. Those are plasmacytomas outside of bone. So for instance, if you do a PET CT scan and find a plasmacytoma, for instance, in the GI tract, that would be evidence of more aggressive disease. Or if there's a mixed response to treatment, that is, it seems like in the serum the myeloma is responding, but you do a bone marrow biopsy and there are still lots of plasma cells around, not significantly decreased from your prior. Other high-risk disease features would be deletion 17p and other high-risk cytogenetics or markers by fluorescence in situ hybridization. If the duration of prior response to treatment, so in those patients who've had a response of longer than 1 year, tend to have lower risk disease than those who do not respond for at least 1 year to treatment, and the presence of end organ damage, as we were talking about before. So what are some patient factors that might influence treatment? Well, age is certainly one of those things we think about. Myeloma is typically a disease of the older population. And so are they fit? Are these the frail elderly, or are these the fit elderly that might be able to handle more than 2 drugs? What is their organ function? Do their kidneys function well? What is their cardiac function? What other comorbidities do they have, including medications that might interact with your drugs? What side effects do they have from previous drugs? They have terrible neuropathy from the bortezomib that we gave in the frontline setting. What's the financial toxicity to the patient? For instance, lenalidomide often costs about $500 a pill. Usually that can be covered well with grants and insurance. However, the out-of-pocket can be quite extreme for some patients, and we often talk about using these medications monthly indefinitely. What is the patient preference, and what is the overall goal of treatment? In addition to, how far is the patient from an infusion center? Are they 3 hours from the nearest infusion center and I should treat them with something all oral? Can they make it back and forth a couple of times a week? So the treatment at first relapse is highly individualized. I would love to have an easy algorithm for you to follow. However, lots of factors come into play here. In fit patients, triplets, which would be a combination of 3 drugs, almost always including dexamethasone, is preferred over doublets. And we'll go over some of that data in just a bit. But the reason for this is because the overall response, or overall survival for multiple myeloma in the relapsed setting is much better with the deeper responses to therapy. And we get deeper responses by using more combinations of drugs. So if you see here, the survival probability, the 50% overall survival, is about, it's more than doubled in patients who get greater than a partial response from their treatment. And the duration of first remission is also very important in thinking about your next line of therapy, because those who have had a duration of first remission of greater than 12 months, you can actually consider reusing the initial treatment. So their disease, as we saw before, might still be sensitive to that first line therapy. However, if it was less than 12 months, you're probably going to consider a new treatment and combination because a new clone has probably arisen. One of the common things that happens, so these patients in first line typically will get the triplet therapy, lenalidomide, bortezomib, and dexamethasone, followed by melphalan, high-dose melphalan with autologous stem cell rescue, followed thereafter by indefinite lenalidomide maintenance. So most patients that we see in 2017 are relapsing on lenalidomide maintenance. So for those who do, what do we do about that? And so there are a couple of approaches. So for those who just have biochemical or indolent relapse, you can simply try to increase the lenalidomide and add dexamethasone. See if you can get treatment effect by adding that back in. You can increase the lenalidomide, add dexamethasone, and add a new agent called elotuzumab, which we'll review in the next slide. And for those with symptomatic or high-risk features, you would typically stop lenalidomide and start a new treatment. So elotuzumab is a drug that's recently been approved. Here's the New England Journal 2015 article that got approval. It's a SLAM F7 monoclonal antibody, and in a phase 3 randomized controlled trial of Revlimid and dexamethasone versus elotuzumab, Revlimid and dexamethasone, in patients who had received 1 to 3 prior treatments, all had lenalidomide-sensitive disease. There was improved progression-free survival without increasing toxicity in the elotuzumab lenalidomide arm versus the lenalidomide dexamethasone arm. And so the 1-year progression-free survival was 68% when you added elotuzumab versus 57% without, and 41 versus 27 at 2 years. So really without increasing much in the way of symptoms, you got better overall response rates and progression-free survival. And for that reason, for most of my patients who are having some biochemical relapse on lenalidomide, I would increase the lenalidomide, add elotuzumab, and add dexamethasone, assuming they're not symptomatic. Another option is, that's all oral, is exhaustive, which is an oral proteasome inhibitor, so it is a cousin of bortezomib. One of the caveats here is that exhaustive is great, but it has to be taken appropriately or it's not effective. So it must be taken 1 hour before or 2 hours after food. And a typical Western diet would reduce the area under the curve and the maximum concentration by about 30 and 70% respectively. So a little bit of food can really make this drug ineffective. In a phase 2 study of exhaustive and dexamethasone in patients with prior bortezomib exposure, there was an overall response rate of 43%. And you can see the waterfall plot here overwhelmingly in favor of exhaustive dexamethasone. It's reasonably well tolerated, and again, another all-oral option. There was about a 16.7-month duration of response in this study. So this is a study of the addition of lenalidomide to exhaustive. So this would be in patients who remain lenalidomide sensitive or who are lenalidomide naive, which are very few in the current days. And this randomized 837 patients to exhaustive, lenalidomide, and dexamethasone versus lenalidomide and dexamethasone. And so this is an all-oral option at relapse. And what they saw were that there was improved progression-free survival when you added exhaustive to the lenalidomide and dexamethasone, very similar to what you saw with elotuzumab data as well. So the median overall survival was not reached in either arm, and the overall response rates were similar but slightly higher in exhaustive versus the control arm of lenalidomide and dexamethasone alone. So adding to this backbone, so using a different proteasome inhibitor called carfilzomib, which is an IV drug combined with lenalidomide, again oral, and dexamethasone in a regimen called KRD. This randomized controlled trial of 792 patients, very similar design. So looking at carfilzomib, lenalidomide, dexamethasone versus lenalidomide and dexamethasone, again in lenalidomide sensitive or naive patients. Also, 2015 also shows that there is improved progression-free survival with the addition of carfilzomib to the backbone of lenalidomide and dexamethasone. There was a benefit of the addition of carfilzomib versus lenalidomide and dexamethasone in all age groups and all risk stratification. So this was good even for high-risk disease and even for older patients. And importantly, it also improved the quality of life scores in the carfilzomib group versus the placebo group. The median overall survival was not reached at a median follow-up of 32 months in this study. This has changed how we treat multiple myeloma and given us a very good option in the relapsed and refractory setting. The hard thing about carfilzomib is it is typically given on days 1, 2, 8, 9, 15, and 16 of a 28-day cycle. And so patients often are coming on Monday, Tuesday, Monday, Tuesday, Monday, Tuesday, and getting a break. So it can be pretty labor-intensive for patients. There is a study looking at higher dose on days 1, 8, and 15. We typically haven't adopted that. We've seen somewhat increased side effects, even though the clinical trial did not report increased effects. So what about swapping out the lenalidomide for pomalidomide, since I told you that most patients have been on lenalidomide? So this study looked at carfilzomib, pomalidomide, and dexamethasone in combination. And it was a phase 1 dose escalation study using a carfilzomib dose of 27 milligrams per meter squared, again given on these back-to-back days once a week. The pomalidomide was given on 4 milligrams days 1 to 21, and that's oral, and dexamethasone 40 milligrams once a week. And at greater than 6 cycles, they considered going to maintenance treatment, which was just carfilzomib given on days 1 to 15 and 16. They excluded patients who were progressing on lenalidomide maintenance, so there is a caveat here, and the patient must have been refractory to full-dose lenalidomide. In this study, they saw an overall response rate of 50%, which is fantastic in this refractory group, and a median progression-free survival of 7.2 months. And so you can see here, this is the progression-free survival estimated in the 95% confidence interval with the addition of pomalidomide to carfilzomib and dexamethasone. So carfilzomib is also carries a warning for cardiac toxicity. And so how serious is the cardiac signal from this drug? Well, it turns out it's pretty low. It's about 5% and does not exceed what's otherwise observed in multiple myeloma patients not on carfilzomib. That said, there are instances where patients are hospitalized on carfilzomib with hypertension, cardiac heart failure, acute myocardial infarction, and cardiac arrhythmias. When I first started using this drug, I had a patient who had a history of VTAC for which he'd had a defibrillator in place. The defibrillator had never fired. He otherwise had a reasonable cardiac function. We discussed the potential risk of carfilzomib, noting that it was low. After 2 doses, his day 1 and 2 of carfilzomib, the following week his defibrillator fired, and he was hospitalized for evaluation. He did not have an acute myocardial infarction, but obviously did not want to go back on carfilzomib. It's unclear if it was directly related, but the timing was suspicious. So it does happen, but it is uncommon. And then our latest and greatest drug is Dedaratumumab. So Dedaratumumab is a monoclonal antibody targeting the myeloma cells, and it's been used in combination with bortezomib and dexamethasone. And in this trial, these were all patients with relapsed refractory multiple myeloma who had received greater than 1 prior line of therapy. They had to have prior bortezomib exposure, but not refractory to bortezomib. And they were randomized in a 1-to-1 fashion to a regimen of bortezomib and dexamethasone, or bortezomib, dexamethasone, and Dedaratumumab. And Dedaratumumab is generally given as an IV with a really long infusion of about 8 hours to 9 hours on the first day. Thereafter, it's about 4 hours. It's initially given weekly, and then it's given every 3 weeks, and then it's spaced out every 4 weeks. The primary endpoint in this study was progression-free survival, and this was published in 2016. And this was phenomenal data. So versus bortezomib and dexamethasone, the median overall, or median progression-free survival was not reached in the Dedaratumumab arm versus 7.2 months in the bortezomib dexamethasone arm. And so the addition of Dedaratumumab significantly improved progression-free survival, also with very little in the way of toxicity. There is some neutropenia seen with Dedaratumumab and some infusion reactions, but otherwise quite well tolerated. So Dedaratumumab has also been used in combination with other agents, including Lenalidomide and Dexamethasone. So very similar trial, all relapsed refractory multiple myeloma, all with greater than one prior line of therapy. They could have prior lenalidomide exposure, but could not have been refractory, and they all had to have a creatinine clearance that was greater than 30 mils per minute, so reasonable kidney function. They were also randomized in a 1-to-1 fashion to lenalidomide dexamethasone versus adding Dedaratumumab. Again, very similar construct. Very similar results as well. So when you added Dedaratumumab, the median progression-free survival was not reached at 13.5 months of follow-up versus 18.4 months median progression-free survival in the Revlimid and dexamethasone arm, or lenalidomide and dexamethasone arm alone. So there was a 63% reduction in the risk of progression-free survival with the addition of Dedaratumumab with little in the way of toxicity. And then swapping out another immunomodulatory agent with Dedaratumumab, so Pomalidomide instead of lenalidomide. Phase 1b trial just got FDA approval for Pomalidomide in combination with Dedaratumumab. 103 patients had to have greater than 2 prior lines of therapies, including a proteasome inhibitor and lenalidomide. This showed an overall response rate of 59%, with some quite deep responses. And remember, I told you in one of the first slides that the depth of response seems to predict how long the patient will survive. So we've got quite deep responses here, with 8% achieving a stringent complete response. And the median time to response is very quick. It's about a month. And the median duration of response seen in this trial was about 13.6 months. So also quite promising results. So hearing that, what would I recommend in a first relapse in patients who are not clinical trial candidates? So I want to reiterate, we don't know how to sequence therapies in multiple myeloma. Even in the front line, we have studies going on because we don't know what's the best. We're adding agents like Dedaratumumab to the standard backbone that we currently have, hoping to improve outcomes. But in patients who are fit for clinical trial, they should be considered for a clinical trial. If they are not, for whatever reason, and they are on maintenance therapy, most will be on maintenance therapy with lenalidomide. For fit patients, I would consider the very active triplets of carfilzomib, pomalidomide, and dexamethasone, or Dedaratumumab, bortezomib, dexamethasone, or Dedaratumumab, pomalidomide, dexamethasone. If the patient was on bortezomib maintenance, I would swap out the proteasome inhibitor with either lenalidomide or carfilzomib and add lenalidomide to the backbone. So triplets, again, because you saw the data that triplets have better, deeper responses and better progression-free survival than doublets. So if the patient is fit and can handle it. For those who have indolent disease or who are frail, you can try triplets. So Dedaratumumab, bortezomib, dex, or exhaustive, cyclophosphamide, dex, exhaustive, lenalidomide, dex, or Dedaratumumab, lenalidomide, dex. You might only be able to get away with doublet therapy in this case, and some is better than none, but if you can tolerate even reduced doses, these are better. Off treatment or no maintenance therapy, then you can pull out what you've used before, assuming the patient has had a response for at least 12 months. So you can try carfilzomib, lenalidomide, dex, Dara, len, dex, or in the indolent with frail disease or indolent disease or frail, you can try the elotuzumab len dex regimen or the exhaustive len dex regimen as well. So again, not a one-size-fits-all. It's can the patient tolerate it? Can they afford it? Can they get to the center? What have they had before? Lots of things to think about. And what is the role of autologous stem cell transplant in relapsed and refractory multiple myeloma? So I told you that at the beginning that most patients will have triplet therapy followed by consolidation therapy with melphalan 200 milligrams per meter squared with autologous stem cell rescue, thereafter followed by lenalidomide maintenance indefinitely. So the Myeloma 10 study was a multi-center randomized open-label phase 3 study in very similar patients who at relapse were reinduced with bortezomib, doxorubicin, and dexamethasone for 4 cycles, and then randomized to a second autologous stem cell transplant versus weekly cyclophosphamide, with the idea being that melphalan and cyclophosphamide, both alkylator therapy, it's not clear if all alkylators are equal and if you can get away with just giving weekly cyclophosphamide. So they enrolled 174 patients, and what they found was that overall survival was better in those patients who went on to receive the autologous stem cell transplant versus the weekly cyclophosphamide, with 67 months overall survival versus 52 months overall survival. So you got a little over a year improvement in overall survival by doing the second transplant, or in transplant in the second line therapy. They also looked at, was the transplant better in the time of first relapse versus second relapse. And what they found was that indeed it was a little bit better if you did it earlier versus later. The thing to remember about stem cell transplants is the patient needs to have had cells. So oftentimes by the time they relapse, they've been on lenalidomide maintenance or maintenance therapy of some sort for quite some time. They've already had a first transplant. So when patients are treated, they are often tried to collect enough stem cells for 2 transplants so that stem cells can be stored in the freezer for later use. So if they don't have stored stem cells, this may not be a feasible option depending on how old and how much prior therapy they've had. And so what about beyond the big 5 that we've just talked about, with the big 5 being lenalidomide, pomalidomide, bortezomib, carfilzomib, and Dedaratumumab? So when you're refractory to each of those agents, that's called penta-refractory disease. So myeloma now has penta-refractory disease. So you can consider autologous stem cell transplantation, as we discussed, and then there are newer agents like panobinostat in combination with bortezomib, and my favorite in combination with high-dose carfilzomib, have some issues in that panobinostat has quite a lot of associated diarrhea, nausea, abdominal cramping, so certainly reserved for a later line of treatment. You can also try a different alkylator with bendamustine in combination with bortezomib and dexamethasone, or lenalidomide and dexamethasone. This is nice because the bendamustine is only given on the first few days of the month, and the rest can be more easily given. And then a new combination of venetoclax with or without bortezomib and dexamethasone, and we'll show that data in just a moment. Also pembrolizumab combinations, as in the Keynotes trials, which are all currently on hold for safety issues. So panobinostat and high-dose carfilzomib have quite nice responses in heavily pretreated patients with relapsed and refractory myeloma. So you can see here the red are very good partial responses. The blue are partial responses. The green is stable disease. And so you can actually have quite a few patients who have good responses, even very good partial responses, on this combination in the penta-refractory setting. So certainly worth a shot if your patient can tolerate it. I found that this combination uses a lower dose of panobinostat at the 20 milligram dose, which seems to be much better tolerated than the 30 milligram typically used in combination with bortezomib. So the diarrhea has not been a major issue, at least in my practice. So venetoclax is an oral therapy, has been very exciting in hematologic malignancies. It is targeting a molecule called BCL2, which is involved in apoptosis. So it is meant to induce apoptosis in the malignant cells. And in a phase 1 open-label trial of 66 patients who had a median of 5 prior therapies, there was an absolute overall response rate of 21% with venetoclax monotherapy. 21% in a very heavily pretreated population is pretty amazing, and it's got us all talking a lot. If you sort that out by those who have the translocation 1114 versus those who don't, you actually see it's the patients with translocation 11-14 who are primarily responding with a 40% overall response rate. And that's again with single agent oral monotherapy. Those without the translocation 11-14 did not fare so well with an overall response rate of only 6%. So this is, as you might imagine, now in clinical trial with lots of other medications in all lines of therapy, including thinking about the front line, as it's got amazing responses here. So it turns out that you can improve that 6% overall response rate in the non-translocation 11-14 myeloma patients by adding other agents. In this study, they used the combination of venetoclax, bortezomib, and dexamethasone. And what you see is that the overall response rate in all comers was 68%, which is absolutely amazing. And in those who were refractory to bortezomib, which are going to be a lot of our patients, still a 24% overall response rate. So very good option for myeloma patients. Not yet FDA approved. The greater number of therapies that the patient has previously had, the less likely there was to be a response, but still 20% response nonetheless, so certainly worth a try. Also in development is an exciting therapy called CAR T-cell therapy. And in this case, a patient has leukapheresis, so their white blood cells are collected. They are incubated with antibody-coated beads to undergo T-cell activation and transduction in a dish, such that you get these modified T-cells that are aimed at a target. In the myeloma case, that target has been BCMA and will be CD38 and CD138 in the upcoming future. You get expansion of the T-cells in the dish. You remove the beads. Then you give the patient some conditioning chemotherapy, very similar to an autologous stem cell transplant, and you infuse the modified T-cells back into the patient. And the results that they've seen when the target was BCMA, or B-cell maturation antigen. So this is a PET-CT scan of a myeloma patient before treatment. So the dark uptake is active myeloma. And this is after 2 weeks of treatment, the PET-CT scan repeated, and you can see a dramatic response to therapy. And you can also see that in the measurement of the serum free light chains. So the serum free light chains go from measurable to essentially unmeasurable by about day 10 here. And then they stayed unmeasurable for, let's say this is day 60. So fantastic response with this. So what should be the duration of treatment in relapsed and refractory myeloma? Well, there's no evidence to guide a duration of therapy. Most of the trials are using indefinite therapy. So some of the trials have built in, you get 6 cycles, and then you de-escalate therapy to some sort of maintenance regimen. But most of our trials do not have that built in, and we don't know how long we should go with triplet therapy. Can we treat to, for instance, stringent complete remission or a molecular remission and then stop therapy or go down to a maintenance dosing? No one knows at this point, but we're hopeful that we'll get some data that will help guide. So most of us will transition to some form of maintenance after a plateaued response. So if a patient doesn't have particularly high-risk disease where you're worried about it coming back soon, as if it progressed in the last year, then you might consider treating to best response, that is an M spike that is no longer going down, or the light chains that are no longer going down, and then try and back off one agent or the other. And usually the agent to back off is the one that's the most difficult. So the dexamethasone, and if it's the IV infusions, skip in some weeks of the IV infusions. And again, minimal residual disease may guide us in the future, but currently we don't have enough data to use it as a guidepost in 2017. I talk about it with most of my patients, but clinically not able to make accurate decisions off of that at this point. So in summary, with our current treatments, the overall survival has certainly increased, but nearly all multiple myeloma patients will relapse. Treatment is indicated when a patient has end organ damage, as in kidney disease, new lytic bone lesions, new extramedullary plasmacytomas, serum calcium greater than 11.5, or they're high risk of end organ damage, as in those who presented with lytic lesions, especially those who presented with lytic lesions that fractured, those who presented in renal failure, or those who are developing kidney injury, and those with a fast myeloma protein doubling time. Triplets, as in 3 drugs, are induce better overall response rates and progression-free survival than doublets in nearly all cases, with increased risk of adverse effects, but generally tolerable, and should be considered in all patients. You might consider doublets in elderly. A well-designed clinical trial should be considered for all myeloma patients at every point in their disease, as there are no current answers as to how best sequence the treatments. And the duration of treatment should be long-term, but you could consider switching to maintenance strategy at some point. I know that's fluffy, but there's currently no data to guide us with that, and so it's honestly a case-by-case basis. And we have several promising therapies in the pipeline, including venetoclax, which is oral, and the CAR-T therapies, which you saw the unprecedented response in that multiply refractory patient previously. Excellent. So with that, I'll ask if there are any questions and leave my email address as contact.
All right, Dr. Reeves, thank you so much. That's fascinating. A lot of information. I know I have questions. I'm sure that many of our audience members do as well. Let me just remind them that they can go ahead. If they haven't already initiated that poll everywhere piece, they can just text the letters UNCCN to the number 22333 one time to join. If you already responded to our poll at the beginning, you've done that. And then you can go ahead and start sending those questions in to us. So none have appeared yet, but I imagine we'll get some. And while we're waiting for those, I've got a few. So I'm imagining that for patients, there's a lot of difficult decisions around managing all the side effects, especially with multiple, triple medications going on in certain cases. I have some general questions about how do patients most effectively do that? How do you work with them to help manage those? One specific one, I know that we've talked a little bit in this program before regarding neuropathy and Taxol and some of the work being done with the hypothermia gloves and boots. Is there anything that shows a similar response yet in terms of bortezomib, in terms of managing the peripheral neuropathy symptoms? Because I know that's been very exciting as far as some of the ways that patients can manage those neuropathy symptoms when receiving Taxol for other types of cancer.
That's right. So we don't know that the mechanism of peripheral neuropathy induced by bortezomib is similar to that with the taxanes.
Gotcha.
So the taxanes in particular have an acute component, an acute pain syndrome, and that seems to precede the neuropathy with them. And so the cold therapy has shown some efficacy there. Okay. With bortezomib, we don't have anything that's shown to reduce that, except the route of administration. So the incidence of peripheral neuropathy is significantly lower if it is administered subcutaneously rather than intravenously. So the standard practice now is that everybody gets subcutaneous bortezomib with a lower incidence. There is in clinical trial a trial of what's called pain scrambler technology, which is similar to a TENS unit. So it looks like an EKG pad. It goes on over, you don't have to place it nicely, over the area of neuropathy. And you come back for several treatments in a row. And in those with chemotherapy-induced neuropathy of all comers, there did look to be an improvement.
Interesting.
It hasn't been specifically studied for bortezomib, but there were patients that were treated with bortezomib in there that seemed to have response. Okay. So perhaps down the pipeline.
Yeah, good to know. We do have questions coming in. First one in response to your, well, actually, the first one was, we think minimal residual disease most important. Should we give Dedaratumumab up front with 2 other agents to get the best response?
Yeah, so Dedaratumumab is showing a lot of promise in multiple myeloma and in combination, as you saw in the Castor and Pollux trials, and then in combination with Pomalidomide as well. So it's pretty well tolerated. It is quite expensive. However, I've started using it in the second and third line settings. We don't know when to sequence these drugs, though, quite frankly. So it's not been put head-to-head with carfilzomib in combination, and I don't know that we're actually going to see that trial. So we don't know. The patient populations, as you saw in the studies, are different, so it's not clear that we're comparing apples and apples when looking at the overall response rates. However, I agree. I think minimal residual disease is important, although we don't currently have any studies that show translation into how we treat and sequence at this point. So it's an individualized approach still. In patients who can afford Dedaratumumab, can tolerate it, don't have significant pulmonary disease, I'm using Dedaratumumab in the second-line setting in conjunction with either Lenalidomide or bortezomib. Most often with bortezomib because most of my patients are Lenalidomide refractory.
Okay. In response to your presentation on the novel agents and their unprecedented responses, can you speak to any possible problems in terms of toxicities?
Sure. So the novel agents, I assume that you're discussing venetoclax and the panobinostat. And the CAR-T as well. So panobinostat, as we discussed, has a lot in the way of diarrhea and GI toxicity, and is usually the rate-limiting symptom for patients. The venetoclax actually is pretty well tolerated. So in CLL, there is a high incidence of tumor lysis syndrome. That does not seem to be the case in multiple myeloma, and it seems to be pretty well tolerated. If you're one of the lucky ones who do respond to venetoclax, it looks to be reasonably well tolerated without significant toxicity. The CAR-T toxicity, so there is chance of cytokine release, and so the therapy is generally administered in the hospital for the first dose. It's not sure how we dose titrate this, but cytokine release can be pretty scary and look like a severe infection, and so it's often monitored in the first doses in the hospital. It'll probably be different for the different antigens that we target. So I'm not sure that we can say one CAR-T target is going to be similar in its effect to the others.
The CAR-T certainly looked very promising in what you'd shown there. What is the prevalence of that right now, and what is the expectation for it?
Yeah, so at UNC we'll be opening a CAR-T trial hopefully in September. There are a few centers in the country currently that have CAR-T for multiple myeloma open. So it's been very promising, not quite as promising as in some of the leukemias. However, certainly something that is hot moving down the pipeline and that we will be directing patients toward.
Good. We're interested in opening multiple myeloma trials at our site. Any good NCI trials?
Tons. You should contact us. Happy to discuss more.
Great. When you see no detectable free chains at 60 days, was it after 2 weeks of therapy only? Or after day 60, excuse me. Was it after 2 weeks of therapy only?
Oh, so in the CAR-T trial, I believe is what you are talking about. So that was a one dose of the CAR-T vector, and so we don't know how many times you have to dose in, right? So how long are those T cells active? But yes, that was at 2 weeks of therapy only.
Okay. Have there been any other CAR-T studies for myeloma with CD30, or have they just been done with BCMA?
So I don't know of any myeloma CD30. I don't know if you're talking about CD38 or CD138, which would be the typical myeloma antigens. Thus far, BCMA. At UNC, we'll be using a different target.
All right. If you have other questions, we have a few more minutes, so please feel free to keep those questions moving. There's anything else that we've covered most of the ones that I had. I was curious. You'd mentioned with it was with was it Ixazomib, the reduction of efficacy with food. How common is that with drug therapies for you to really have that lowered efficacy around food?
That is actually a pretty interesting one. So it's one of the few I know in multiple myeloma, but it's pretty big. So
Yeah.
they're actually putting, so the company is giving magnets for the patients to remember flashes for when you're supposed to take the drug, and a reminder right on there to not take with food. Because as you can imagine, if you think that the drug isn't active, but it's actually not active because the patient is eating and not effectively getting any drug, you might actually be able to use it.
Yeah. No. All right. Thank you. And we've got just a moment left for questions. Any other questions? Thank you for all those questions that you have submitted. And Dr. Reeves did leave her email address. That was in one of the slides. Great segue for me to say, if you need to go back and see those slides, those will all be on our library site, our video library site. Those will be on our YouTube site, and then the slides are available as well. We want to thank Dr. Reeves for being here today. We want to thank our audience for being here today, and we hope that you'll join us for many of the presentations in the future. We want to thank the University Cancer Research Fund and the state of North Carolina for their generous support of UCRF and of the UNC Lineberger Comprehensive Cancer Center. So we're very appreciative for that, as we are for the expertise of Mary King, Veneranda Obore, and Alan Brown, who work very diligently to make all of this possible. We've got more lectures, always more lectures. You can find all of our lectures on our events section of our website at unccn.org. On June 30th, a Lunch and Learn lecture, Understanding and Living with Chemobrain. I've heard Dr. Thompson before. This is a fascinating lecture, and I'm sure she'll have some updates as well. July 12th, RN and Allied Health lecture, Caring for Older Adults with Cancer. Who, when, where, why, and how, with Trevor Jolly. So we're looking forward to that. And then on July 26th, another medical and surgical oncology lecture, New Options for Immunotherapy, Where We Are and Where We're Going, with Dr. Benjamin Vincent. So looking forward to all of those. We hope you'll be able to join us for some or all of those. Our community lunch and learn lectures are geared toward the general public and anyone touched by cancer. The other ones have various continuing education certifications associated with them. All right. If you have any questions, you can get back to us. We've got lots of ways you can reach us. Again, best way is just to find us on the web at unccn.org. Thank you so much, and until next time, hope you have a great week ahead.